I will discuss granulomatous inflammation today. Granulomatous inflammation is a form of chronic inflammation characterized by collections of activated macrophages, often with T lymphocytes and sometimes associated with central necrosis. The activated macrophages may develop abundant cytoplasm and begin to resemble epithelial cells, hence they are called epithelioid cells. Some activated macrophages may fuse, forming multinucleated giant cells. Granuloma formation is a cellular attempt to contain an offending agent that is difficult to eradicate. Granuloma formation occurs in the setting of persistent T cell responses to certain microbes such as Mycobacterium tuberculosis, Treponema pallidum, or fungi. T cell derived cytokines are responsible for chronic macrophage activation and granuloma formation. Tuberculosis is the prototype of a granulomatous disease caused by infection and should always be excluded as the cause when granulomas are identified. In this disease, the granuloma is referred to as tubercle. Here is the case scenario. A 9-year-old boy has had a chronic cough, low-grade fever, night sweats for the past month. Chest radiograph shows cavitating lesion in right lung. A sputum sample contains acid-fast bacilli. So, this patient presents with low-grade fever and chronic cough for past month. This is a typical scenario for tuberculosis. Also supporting evidences, there are cavitating lesions in the right lung and sputum sample shows acid-fast bacilli, that is the characteristic of Mycobacterium tuberculosis. The questions mostly asked are: name the type of an inflammation, components of granuloma, etiological classification of granulomatous inflammation, and role of macrophage in this type of inflammation. First interaction of Mycobacterium tuberculosis is with the resident macrophage, alveolar macrophage. Alveolar macrophage then present antigen to the T cell and also secrete interleukin 12 to activate T cell. Helper T cell class 1 is activated and it produces interferon gamma that activates macrophage. Activated macrophage secretes several chemokines and mediators that recruits lots of other macrophages and leukocytes that are necessary for granuloma formation. They also upregulate nitric oxide and reactive oxygen species to enhance their bactericidal activity. This is the gross picture of lung. You can appreciate here areas of caseous necrosis. This is cut section of a lymph node of a tuberculosis patient. Gray-white areas of cheesy necrosis. Morphology of chronic granulomatous inflammation. In the usual H&E stained tissue samples, the activated macrophages in granulomas have pink granulocytoplasm with indistinct cell boundaries and are called epithelioid cells. A collar of lymphocytes surrounds the aggregate of epithelioid macrophages. Older granuloma may have a rim of fibroblasts and connective tissue. Multinucleated giant cells 40 to 15 micrometer in diameters are found in granulomas. These are called Langhans giant cells. They consist of a large mass of cytoplasm and many nuclei. So, this is the necrotic center, areas of caseous necrosis. This horseshoe-shaped arrangement of the nuclei, this is called Langhans type giant cells. And these small dots are lymphocytes. And you can appreciate here slipper-shaped epithelioid cells, those are activated macrophages. So the combination of all these components is called granuloma. Areas of central caseous necrosis, Langhans giant cells, epithelioid cells, and lymphocytes. This is typical Langhans giant cells where nuclei are arranged in horseshoe-shaped arrangement. These cells are epithelioid cells. These darkly stained round blue cells are lymphocytes. This is foreign body type giant cells in which nuclei are centrally placed, in contrast to the Langhans giant cells where nuclei were peripherally arranged. These are the Teuton giant cells. They are common in xanthoma. These are the lipid vacuoles in the cytoplasm of the macrophages. These are tumor giant cells. They are found in anaplastic tumors. Rh cells, they are typical of Hodgkin lymphoma, where two nucleus are mirror images of each other. There are two types of granuloma. First one is immune granuloma. They are caused by a variety of agents that are capable of inducing a persistent T-cell mediated response. Etiology: present at macro or self-antigen. In such responses, macrophage activates T-cell to produce cytokines such as interleukin-2, which activates other T-cells sustaining a response, and interferon gamma, which activates macrophages. Foreign body granulomas are seen in response to relatively inert foreign bodies in the absence of T-cell mediated responses. Typically, foreign body granulomas form around materials such as talc, associated with IV drug abuses, sutures, or other fibers. Epithelioid cells and giant cells are opposed to the surface of foreign body. The foreign material can usually be identified in the center of granuloma. These are the suture material, and these are foreign body type giant cells and collection of epithelioid cells. This is foreign body type granuloma that is formed against suture material. Again, these are foreign body type giant cells in which nuclei are centrally placed, and this is the foreign body. On the basis of morphological features, granuloma can be divided into two: caseating granulomas and non-caseating granulomas. Caseating granulomas are associated with certain infections like Mycobacterium tuberculosis. They have a central zone of necrosis. Grossly, this has a granular cheesy appearance and is therefore called caseous necrosis. Microscopically, this necrotic material appears as amorphous, structureless, eosinophilic, granular debris with loss of cellular details. While non-caseating granulomas, these granulomas are present in Crohn's disease and sarcoidosis. They tend to not to have necrotic center and are said to be non-caseating. Granulomas may also develop in some immune-mediated inflammatory disease like Crohn's disease, which is one type of inflammatory bowel disease and an important cause of granulomatous inflammation in the United States. You can appreciate here clonic glands, and this is the non-caseating one. There is absence of necrotic center. Sarcoidosis is a disease of unknown etiology. It presents with bilateral hilar lymphadenopathy. In contrast to caseating granulomas with central areas of caseous necrosis, they lack area of necrosis. Fungal granuloma are found around the hyphae or spores of the fungus. This is the well circumscribed fungal granuloma with foreign body type giant cell. Here is etiological classification of granulomatous inflammation. In tuberculosis, caseated granulomas are present, and tuberculosis is caused by Mycobacterium tuberculosis. In leprosy, non-caseating granulomas are present, and leprosy is caused by Mycobacterium leprae. Syphilis is caused by Treponema pallidum, and in this disease, microscopic to grossly visible lesions occur. In gastric disease, round or stellate granulomas containing cellular granular debris and recognizable neutrophils occur. Giant cells are uncommon. In Crohn's and sarcoidosis, non-caseating granulomas form. So, in histological examination, we can differentiate different types of granuloma on the basis of several tests. Acid-fast stains we can use for tubercle bacilli, and we can do cultures for tuberculosis or fungal disease, and we can use molecular techniques like PCR for tuberculosis, and we can do serological studies for syphilis. 1 month after an appendicectomy, a 25-year-old woman palpates a small nodule beneath the skin at the site of healed right lower quadrant. Nodule is excised and microscopic examination shows macrophages, collagens, and lymphocytes and multinucleated giant cells. Polarizable refractile material is seen. Which of the following complication best accounts? So polarizable refractile material is suture, and this all scenario is of granuloma. So the option suture granuloma is correct. Talking about systemic effects of inflammation. Inflammation, even if it's localized, is associated with cytokine-induced systemic reaction that are collectively called acute phase responses. These changes are reaction to cytokines TNF, interleukin-1 and interleukin-6. Fever characterized by elevation of body temperature usually by 1 to 4 degrees centigrade. It's caused by endogenous or exogenous pyrogens. Endogenous pyrogens are TNF and interleukin-1 secreted by leukocytes, while exogenous pyrogens are lipopolysaccharides of microbes. In hypothalamus, prostaglandins, especially prostaglandin E2, stimulate the production of neurotransmitter that reset the temperature set point at a higher level. Other manifestations are increased heart rate, decreased sweating, rigors, chills. High levels of cytokines can cause DIC or septic shock. 3 of the best known proteins are CRP, fibrinogen, serum amyloid proteins. CRP levels are important indicator of inflammation, and they are also marker for increased risk of myocardial infarction. ESR, erythrocyte sedimentation rate. Fibrinogen binds to red cells and causes them to form stack Rolex that sediments more rapidly at unit gravity than do individual red cells. This is the basis for measuring erythrocyte sedimentation rate as a sample test for an inflammatory response caused by any stimulus. So raised ESR is indicator of inflammation. Anemia of chronic disease. Another peptide whose production is increased is hepcidin. Chronically elevated plasma concentration reduce the availability of iron associated with chronic inflammation. Leukocyte count in inflammation. In inflammation, leukocytosis occur, and neutrophilia is most common in bacterial infection, while in viral infection, lymphocytosis occur. Eosinophilia occurs in allergies and parasitic infection, while in some infections like typhoid, leukopenia occur. Here's a case scenario for you for your assignments. You have to submit this assignment, attempt all the questions, and send it to the designated person. Thank you.